Thank you, Dr. Namta, for the opportunity. And I'll be talking about acute chemical injury. And as she told, that it is really a true ocular emergency because it has to be managed as early as possible and try to prevent the damage as far as possible. The common agents are alkalis and acids, and the acid injury causes less of damage because it causes denaturation of proteins. There is collagen shrinkage, so the penetration of the chemical is less. But in alkali, there is saponification of lipids in the cell membrane, and that leads to hydrolysis of the cell wall and causes deeper penetration. So so the basic aim of management, as I said, that we should prevent the damage, and for that we have to do a complete removal of chemical from the eye, and control of acute inflammatory reaction should be done, and you should prevent complications, something like this, to happen, so that you don't end up in multiple interventions, and in spite of that, there can be suboptimal visual outcome. The prognosis depends not only on severity of injury, but also on the rapidity with which therapy is initiated. And that's why, as I said, that the prevention of sequelae is the key. And the management of acute chemical injury can be divided into immediate management, that you have to, take care of the chemical that has come into the eye, and the early management, like you have to take care of the inflammation, etc. So the first aid or the immediate management is irrigation. Irrigation is done on an average for about 25 to 30 minutes. However, the time is not the guiding factor. The guiding factor is the pH, and the pH should return to normal. So pH paper should definitely be used. Only precaution one should do is that one should wait for 5 minutes once you have completely stopped the irrigation, and then do check the pH, because otherwise it will show the pH of the irrigating solution, the washing solution that you are is being used. Now, washing can be done by anything. I mean, if the chemical is gone, one should immediately look at the nearby tap and can wash it with tap water as far as possible, and then report to any hospital wherein the thorough wash can be done by averting the lids, etc., so that you can remove the chemical completely. So that is the basic aim, and the final aim is to attain the pH of 7.3, 7.4, close to that. Now, one should definitely try to do double eversion of lid. Sometimes what happens is the chemical goes into the furnaces and gets stuck there. So double eversion of lid should be done, and the patient should be asked to look down so that the furnaces can be seen and one can remove the particulate matter from that area. As I said, there are various ways of removing the chemical. Even the tap water can be used. And the best solution that has been shown in literature is balanced salt solution, BSS plus. However, ringer lactate is also very good, and that is available everywhere in any emergency situation. Then once the epithelium, once the chemical has been removed by washing and by checking the pH, and after double eversion, remove the particulate matter, we should see how much is the damage. So the basic idea is to promote epithelialization, support repair, and minimize ulceration and control inflammation. So for that, the assessment of severity should be done. It is very essential to assess the severity by checking the size of epithelial defect, and also checking the limbal ischemia, and so that it is not just theoretical, rather it gives you an idea that what all you have to do. The management differs with different grades, and you can also explain the prognosis to the patient. This is the old classification, or I would say the gold standard classification of chemical injury. That was the Roper Hall classification, which divided into 4 grades of chemical injury. The 4th grade had more than half of limbal ischemia. Now, more than half can have various variable prognosis. Somebody can have 200 degrees of ischemia, somebody can have 360-degree ischemia. So the prognosis was very variable, and that is what has been done in Dua's classification. They have classified the fourth group into three parts, and that is how they could explain the prognosis better, and the management pattern differs with this. And this is one study from our center which states that the Dua's classification is better in terms of explaining the prognosis to the patient. Once the damage has been assessed, then what we should do is we should debride the necrotic material. Then the patient is given some medication to reduce the symptoms, analgesic, topical antibiotics, lubrication is given, cycloplegics, and topical steroids should be given. Apart from that, depending upon the severity of injury, if the injury is more, there is some stromal involvement, then in that case, it is very essential to prevent damage to the collagen, the stromal collagen. And for that, ascorbate and citrate are very useful. Now, ascorbate acts as a cofactor, which helps in collagen synthesis, and citrate prevents the collection of polymorphs. So the release of collagenase is stopped by inhibiting the polymorphs by sodium citrate, and thereby it prevents the damage to the corneal stroma. And the same way, doxycycline is also used as a collagenase inhibitor to prevent damage to the stromal collagen. And systemic sodium ascorbate is given 1 gram twice a day, or 500 milligram 4 times a day, whatever you feel like. Autologous serum has been found to be quite effective in severe cases, and there's one study done under the guidance of Dr. Namta Sharma at RP Center, wherein it was compared, umbilical cord serum and the autologous serum was compared, and they found that the umbilical cord serum was even better than autologous serum. Sometimes what you see that the particulate matter has gone in deep underneath the conjunctiva. So in that case, you cannot leave any particulate matter, because that will not only cause the persistent damage, it will cause more and more episcleral ischemia, then scleral ischemia, and scleral melting. All sorts of things can happen. So it is very essential to remove the particulate matter, even by going underneath the conjunctiva, remove all these the chemical agent from underneath. And then once you have done it, then you can put an amniotic membrane over the surface, and it will heal. Amniotic membrane has been found to be quite effective. It not only aids in epithelial defect, it provides symptomatic relief in the patient. There was one study done at our center which showed that the amniotic membrane is really useful, not only in improving epithelialization in cases of chemical injury, but also it reduces inflammation, and it reduces pain in the patient. So amniotic membrane at a period maybe at around 7 or 10 days time, or sometimes when you see that the epithelium is not healing, in that case amniotic membrane can be used. As I said, topical steroid can be used for 10 days or maybe extended up to 14 days. Sometimes what happens is the inflammation is quite severe. In that case, and the epithelium is not healing, then you can use amniotic membrane and also put topical steroid for another week or so. And that is how you actually titrate your depending upon the severity of the patient. And this is one patient where an amniotic membrane graft was done, and the epithelial healing and the stromal clarity improved. This is one study which I was talking about. Dr. Amol Tamane was the resident who had done the thesis at RP Center, and they found out that amniotic membrane transplantation in acute chemical burns as an early therapy done at between 10 to 14 days time after the injury, improved epithelialization, reduced pain, and reduced symptom of the patient, reduced inflammation. And there are various studies which have shown that amniotic membrane transplantation is quite effective in early improvement of the cases of chemical injury. Apart from that, conjunctival advancement or tenonplasty or multilayered AMG can be done if there is any stromal melting. Now, tenonplasty has shown in cases of scleral ischemia, in cases of the ischemia which is quite severe, the episcleral and the scleral ischemia. In that case, tenonplasty, pedicle graft of tenon really helps in vascularization of that area and prevents the scleral melting. So To end my discussion about the management of acute chemical injury, there are certain things that we should think about. As the theme of the symposium is to give take-home message to the delegates on 3 points, on three parameters. One is how to diagnose. So as far as chemical injury is concerned, there will be a definitive history of injury by chemical. Then the patient will have symptoms like pain, redness, photophobia, and blurring. And then you will be seeing the corneal epithelial haze. There can be defect, there can be stromal haze, and there can be limbal ischemia. And based on all these, you can easily diagnose. And of course, the 99% of the patient will be telling you about the history of chemical injury. As far as treatment is concerned, it depends on the severity of chemical injury. Suppose somebody has a very mild chemical injury, grade 1 injury. In that case, you can just put lubricant, topical steroid, and epithelial friendly antibiotic prophylaxis, say something like chloramphenicol, etc., whatever. And then the patient will have a nice clearing of the whatever epithelial haze is there, and that will go off. As the severity increases, once it goes to grade 2, grade 3, you add more things like topical steroid. Of course, you have to give ascorbate, citrate, and doxycycline is given. And in further severe injuries, you can, do all these tenonplasty or autologous serum and amniotic membrane transplantation can be done in cases once it is more severe and not resolving. But the most important thing that I would like to highlight is to remove the chemical from the eye. That can be done in any setting, even in a village, that can be done, because it can be washed off even with the tap water. So that is most important. You should manage, you should remove the chemical from the eye by saline wash, check the pH if the pH paper is available, and try to evert the lids and see if there is particulate matter. That should be removed. And if once you have done the immediate management and the early management, then if you see that the patient is having marked epithelial defect or the stromal haze and significant limbal ischemia, wherein you have doubt that there will be episcleral ischemia, there can be even scleral melts, etc., or there can be corneal melts, or the patient is having secondary glaucoma, because chemical can cause damage to the trabecular meshwork, and that can lead to secondary glaucoma, or there is a symbliphron formation because of the conjunctival damage or conjunctivalization of cornea. In all these situations, one should definitely refer the patient to a specialist, cornea specialist, who can handle such cases in a more specialized and focused manner. So thank you very much for your patient listening. Now we have